Use the next speaker, Dr. Kamal KAPUR, who is going to speak on risk-benefit analysis in refractive lens exchange.
Very good afternoon. Heartfelt gratitude and thank you to Dr. Olio for involving me in this course. Most of the topic has already been covered by him. He's a trailblazer, and in fact, I was just sharing with my friend sitting there, for last 20 years, he looks the same, he acts the same, and he probably has more energy than he had 20 years ago. So I'll be talking about the limitations, innovations, and outcomes. There will be some crossover between my talk and Professor Olio's talk. I have no financial disclaimer here. So refractive lens exchange is the removal of a clear lens of the eye. Simple procedure. The intention is to correct the refraction. Let's be very clear about that. It did go into a disrepute because suddenly it caught on in Europe, and there was a lot of retina detachments and other associated complications, but then it has come back again. And I will not repeat the same slide. I've had a similar slide by Professor Olio here. It was started in 1776, and then it caught on by Dr. Fukala. But then, in a little short interval of time, a lot of retina detachments, especially myopes, it went into disrepute. What are the optical indications? Of course, emmetropia, especially hypermetropia. We all will understand and agree that hypermetropia is a very, very good indication for a refractive lens exchange, and irrespective of the age of the patient also as compared to the myopic age group. Anisometropia is probably one of reasons for choice. Presbyopia, especially with the availability of very good quality of diffractive multifocals, trifocals, enhanced monofocals, and even EDOFs. Correction of astigmatism. If I get time, I will be showing some patients where I've done refractive lens exchange for patients with 14 diopters of astigmatism, patients with keratoconus, and they've had amazing results. And of course, the concept of dysfunctional lens syndrome. I've been talking about dysfunctional lens syndrome for last 5-6 years, and my partner, Dr. Samir, for those who know him, had 6/6 vision, but he had a DLS. So we ran a DLI score for him on the Tracy. He was having some trouble while playing golf, but he was operating every day. So I went ahead and operated him, and he's super happy. So let us see what are the categories which we would divide the cataract surgical practice is. Of course, the classical refractive lens exchange, where the lens is removed only to take care of the refraction. And then you have cataract surgery, where the lens has opacified, you remove it. Then you have refractive cataract surgery, where you remove the cataractous lens, also correct the refraction. Then you have the DLS surgery, where the lens probably by standard LOCS scale is clear, but it is causing some aberrations. It is eating into the optical quality. So it is called the DLS, the dysfunctional lens syndrome, and you could do a DLI score on the Tracy and show it to the patient, and these patients do very well. And the last category is the refractive dysfunctional lens surgery, which means the patient has a DLS and he also has a refraction, which is my partner. He had -3.5 with a DLS. So he did fantastically well. So what does DLS actually do? The patient may be actually seeing 20/20 or 6/6, but the optical quality may not be very, very high. The patient may complain of issues. By technical classical methodology, the patient may not be having a cataract, but it's a dysfunctional lens, which means it is not a non-functional lens, it's a dysfunctional lens. So these lenses will cause loss of contrast, and this is how you scale it on the Tracy machine. And if the scale is, in my cutoff, if it's less than 7, I do give the patient an option of going in for a DLS surgery. This is what probably a loss of contrast can look. I'm trying to simulate it for a patient with a DLS, though he's seeing everything very clear, but there is a loss of contrast, the colors are lost, and the brightness is lost. So refractive lens exchange, in my practice, I would usually consider it when the patient is not able to do it for a phakic lens, not fit for LASIK, and is above age of 45. We usually avoid operating younger patients for refractive lens exchange, especially if they are high myopes. But hypermetropes do very well with this. So a younger patient of hypermetropes also, it's a good surgical procedure to be done. The advantage is that the optical quality as compared to a higher refractive correction on the corneal plane, the optical quality with a refractive lens exchange is very, very good. There are no associated dry eyes, no loss of biomechanical strength for the patient, and the greater the correction, better is the quality of vision in these patients. What would be the limitations? Now, some of the risk-benefit analysis, let's see. Whenever you're treating a patient with a high myopia, high axial length, there are very, very strong chamber fluctuations in these patients. And what can happen is these chamber fluctuations itself can cause problems in the vitreous and may cause retina detachment at a later date. There are a lot of studies which do say that the incidence of retina detachment go up to 6% in very high myopes. And also, if you case operating the surgery under block, you can have a perforation. There are reported chances of retina detachment in younger patients, especially when the PVD is not happening. But in hyperopic patients, I have personally experienced, I've operated, I'll be showing some videos, plus 45 diopters of IOL, plus 48 diopters of IOL. Now, of course, I use a piggyback for these patients, not a single lens. But these patients, one of the patients did have an intraoperative very high pressure, which needed to be controlled, and it did scare the daylights out of me. So as I said, relax in high myopes can cause RD. Incidence is 1.5 to nearly 6%. There are various literature formulas available there. The concerns, what are our concerns is when you're operating the patient for a refractive lens exchange, the purpose is refractive correction. So you have to be very, very good with your IOL power selection. Luckily for us, there are amazing number of IOL formulas which are available, which we can use, we can tailor to our, standardize our own A constants. We must share with the patient that there will be a loss of accommodation. If in case you go in for the EDOF category of lenses, we definitely give a very good intermediate vision. Using multifocal lenses in high myopic patients, sometimes I burned my hand because of very large pupil sizes. These patients will have photic phenomenon, and these patients may come back to you with more photic phenomenon than your average patient with trifocal or a bifocal. Near glass dependency has to be explained to these patients. What we normally do in patients who are myopic is we do a monovision or a micromonovision after we tested the dominant eye, looking for kappa angle and keratometry, and also looking out for surface disorders, because these patients, if they have surface disorders, they are not going to be very happy because of bad keratometric values which you've taken in, and also post-operative surgery. Now, what are the issues you may have once you have a patient who's got a high myopia and he has a PCO? There are studies which say that when you do a YAG laser for these patients, the incidence of retina detachment is shown to go up. So there are some tricks which are given in the literature which you can use to do during the surgery so that your PCO is less. You make sure that your capsular axis covers the anterior edge of the lens. Cortical cleaving hydrodissection, make sure that the little fibrils and the epithelium on the bag is taken away. Meticulous cortical cleanup, and using special sharp edge lenses which make sure that the migration of the cells do not happen. Another plus point is having very, very high-end machines which give you controlled anterior chamber, so lesser number of fluctuations. Using of bimanual instrumentation, of course, has made the surgery far more safer in our myopic patients also. Now, how to avoid complications by preoperative screening? You do a meticulous preoperative screening. I always ensure when I'm operating a high myope, even if I'm doing a LASIK or a phakic lens, there's scleral depression, a complete screening by the posterior segment surgeon. Young eyes, be very, very careful. As far as possible, avoid doing, at least in my practice, RLE in very young patients. For high myopia, we prefer giving them other options like contact lens in case they cannot be operated by other methods available, lacquer cracks, and any history of retina detachment earlier is a strict no for me. Of course, in hypermetropia, there are a lot of plus points. As it is, these patients have smaller anterior chamber, shallower angles. So doing RLE in these patients will be beneficial for them, and also take care of their thick glasses, which actually give a lot of chromatic aberrations. And the best part is if the axial length is less than 21, this is where you should watch out. I prefer giving these patients perioperative mannitol and Diamox tablet in the morning, and I always give a block to the hypermetropic patients, at least in my practice, in my hands, because I've suffered once or twice. It's a good idea to give the block and give a hypertonic because you do get extra anterior chamber depth in these patients. So what are the innovations? There are various innovations. You have a monovision option. You have a micro monovision. a toric monofocal, toric bifocal, trifocal, enhanced monofocals. Now this is, I think, it's something very unique and very interesting which has happened to our practice, where you're not very sure about the aberrations which the lens may cause problem to the patient. You can go in for an enhanced monofocal with a blended vision of overcorrecting the non-dominant eye by 0.5 diopters. Flax also is giving a huge benefit by giving you a very, very accurate markings and placements of your lens. Piggyback lenses, number of formulas are available. Whatever works for you best in your practice. We are using a lot of Barrett suite in our calculations. Another plus point is the smaller the incision, lesser the fluctuations, safer the surgery, faster the surgery. Newer designs of lenses have been proven to be better. Now, monovision is practically out of practice in my practice, because when you need to give a difference of 1.5 diopters, it's not a very, very good thing to have. I prefer doing the micro mini monovision. What I practically do is I do correct the second myopia on my biometry. Suppose my first correction is 0.12 myopia, I go in for the second one, which is 0.38 or 0.4. So the second eye, or the eye which is non-dominant, goes for the second correction of myopia on the biometer. Make sure your patient is intelligent when you're planning a micro monovision or a monovision. You've explained it to them, do a contact lens trial or even a spectacle trial on a trial frame to make them understand what it means, because sometimes they will come back and haunt you. They may have said yes in eagerness that, okay, we are okay with micro monovision or monovision, but once you have operated them, they will come and bother you. Ideally, I would take any patient above the age of 45. The power range we will see in the videos which we go forward: dilated retina examination, determination of the dominant eye, bimanual detailed indirect ophthalmoscopy in myopes, very, very accurate biometry, and also record all the astigmatic. So you can actually do a time interval between 5 to 7 days is what I do in my practice. I give 5 to 7 days between one eye and second eye, because it gives me enough time to actually estimate how is the refraction ending up. I always operate the non-dominant eye first if I'm doing an RLE. The reason being, it's a bit more forgiving for me. It helps me to titrate my end result. So I operate the non-dominant eye first, and after 5 to 7 days, I take the second eye first. Pupil size issues, definitely if you have a very large pupil size, you do get caught up. Now this is what I said. Hypermetropia, I prefer giving a block. In myopes, it's a good idea to avoid a block. But one good thing is that myopes, due to the chamber fluctuations, will have a lot of pain. I prefer using Xalocaine intracameral during the surgery, Oculan or whatever it's called locally, no commercial interest here. Just inject that to make sure that the patient doesn't experience the pressure fluctuations. The patient, especially these high refractive error, do notice increase in their visual acuity, reduction of their aberrations. Now, these are some of the surgical patients I've operated. This is a cylinder of 8 diopters with plus 30, cylinder of -1 with 5 diopters. We will see this, and especially some customized lenses with plus 55 diopters. Now we will see this. This is a patient where we'll just whiz through. These are all clear lens extractions. We do the rexes, small rexes, make sure the lens rexes covers this. So this is 2.5 with the 43 diopters. Very simple. It's not the surgery which is important. I guess it's finding the right formula, making sure your rexes is covered, and we're using an ultra smart lens here. This is a -3 diopter sphere with a 4 diopter cylinder, again high myope. There'll be some interesting videos as we go along. Now, these are all simple things. What I'm just wanting to demonstrate is concentrate on your rexes. Make sure there's not fluctuation on the anterior chamber. It's a -3 diopters with a 4 diopter cylinder. Again, a customized lens implanted. Now, this is a refractive lens exchange for a 51-year-old patient. He's a very famous jeweler in Delhi. And I did a C3R for him many years ago. And he had some amount of cataract here also, but it was not interfering. So what I did was I knew that he improves with spectacles till a particular level. So which means the astigmatism was corneal. We ran an eye tracy on him, and we could see that it's most of a corneal astigmatism due to the keratoconus. And see what we got, a customized 14.5 diopters of astigmatism. And it's a customized lens. All you need to do is place the lens bang accurately, and this patient was super happy. 6/12 vision unaided. The best he ever saw with glasses was 6/18, and with contact lens, he was seeing 6.9, but he was getting a contact lens intolerance. So we shifted him and gave him this option. We first operated one eye, gave him enough time to wait and settle into it, and then we took care of the second eye. So this is what you can actually do if you isolated that the astigmatism is more due to the cornea. There are sometimes there could be lenticular contributions to the astigmatism, so don't end up correcting that, because then you will be landing in trouble. This is a patient post PK. Again, this is 11 diopters, astigmatism, operated, customized lens, done, dusted, patient doing very well. Very, very interesting cases. Now, this is an IntelliAxis, astigmatic correction, again. This is, again, a clear lens extraction, 34.5 diopters. And there you go. Sorry. Now, we put a trifocal lens in this. This was a lady who wanted this. Again, -6 diopters. So there are plenty of such cases. So refractive lens exchange, I think in the conclusion, is a very, very good procedure. Once you have a very good case selection, you stick to the ethics. You do not operate patients where you should not be operating. A good surgeon should also be able to say no to the patient. That, okay, I would not recommend a surgery because it may cause problems for you later on. So I think refractive lens exchange with all the current armory has a lot of benefits. Once you mitigated the risk, it's a good surgery to do. Thank you.